I want to also join Victor and others in thanking Dr. Lander for his remarks. And it's always hard to stop something that is incredibly interesting, but we have wonderful panels, and I think many of the topics that Dr. Lander raised are going to get unpacked more in our panels. So let me introduce our first panel. This panel is Disruption, Construction, and Learning from COVID-19, and it will be moderated by Carl Zimmer. Carl Zimmer is the author of 14 books about science, and he is a columnist for the New York Times. Zimmer started his career at Discover, where he served as a senior editor for 4 years. He went on to write hundreds of articles for magazines, including National Geographic, The Atlantic, and Wired. Carl has contributed to the New York Times since 2004 and has been a columnist since 2013. Not surprisingly, his journalism has won numerous awards from the American Association for the Advancement of Science, the National Academies of Science, the National Association of Science Writers. His books include Life's Edge, The Search for What It Means to Be Alive, published this March, and She Has Her Mother's Laugh, The Powers, Perversions, and Potential of Heredity, which won the 2018 National Academies Communication Award. Carl is professor adjunct in the Department of Molecular Biophysics and Biochemistry at Yale University. Please join me in welcoming Carl.
Thank you, Dr. Curry. I'm very glad to be here, and it's going to be a really fascinating panel. We're going to have 4 scientists who are going to share their thoughts about what we've been through scientifically and medically so far in this pandemic, and what lessons they think we have learned or should have learned. And I think that this is a really, this is a really crucial thing for the scientific community to be doing at this point and moving forward. I was actually inspired as I was preparing for this panel to go back and look over a century ago at the pandemic that last wreaked so much havoc on our country, the flu pandemic of 1918. There really hasn't been anything to compare to COVID-19 since then. And what really struck me was how the scientists and doctors themselves were grappling with the mystery of what they were contending with. You have to bear in mind that that they did not really know what caused the pandemic. We were able to identify SARS-CoV-2 just in a matter of weeks as the cause of COVID-19. But when it came to the flu, people thought it was caused by bacteria. The flu virus would not be discovered until 15 years later. And so, there's this one passage that really captured my attention from a Harvard doctor named Milton Rosenau. He published a paper in 1918 where he was puzzling over how he couldn't link the flu to a kind of bacteria that people thought was the cause of the flu. And he wrote, "We entered the outbreak with a notion that we knew the cause of the disease, and we're quite sure we know how it was transmitted from person to person. Perhaps if we have learned anything, it is that we are not quite sure what we know about the disease." Now, just 3 years later, Rosenau's protege, Warren Vaughn, published a magisterial book called Influenza, an epidemiological study. And Vaughn was putting forward some of the important lessons that actually had been learned by looking at how the virus spread from person to person, the kinds of things that could slow its spread, and so on. And he closes the book with this marvelous line, which I think kind of applies to what we're going to be talking about today. He said, "Much work has been done and great experience gained by both the physicians and the nursing organizations during the last epidemic. Now is the time to prepare for the next epidemic or pandemic. With the remembrance of 1918 fresh in our minds, we can establish a working system. While if we delay until the expected arrival of another epidemic, much of our painfully acquired knowledge will have been forgotten. So I think today we're going to learn about some of the lessons that scientists and doctors have been learning, not just about the virus itself, but how pandemics are managed, should be managed, how structural weaknesses in our healthcare lead us to be vulnerable to pandemics, and how important even communication can be to the fate of a pandemic. So we will start with Akiko Iwasaki. Akiko has her slides up already, but I'll just quickly introduce her. Akiko is the Waldemar von Zedwitz Professor of Immunobiology and of Molecular, Cellular, and Developmental Biology, and Professor of Epidemiology and of Dermatology at the Yale School of Medicine. She's also an investigator at the Howard Hughes Medical Institute. So I'll leave it to you, Akiko.
Thank you, Carl. So I'd like to speak to this panel about my own personal learnings during the pandemic. And I titled my talk From Bench to Bedside and to the World to reflect some of the learnings that I've gained through my team's wet bench science, as well as learning from the patients, and also how we as scientists communicate with the world. So next slide, please. So just a little background about myself. I'm still a basic scientist. We used to do a lot of animal models to model viral infection and diseases, and trying to understand how we can leverage that understanding to make better vaccines. So this whole panel is really entitled Disruption, Construction, and Learning. And so there was no bigger disruption to my lab's research than the COVID-19 in the history of our lab. And essentially one day, everything was shut down, and we had been doing all kinds of other research on viral immunity, but most of us just dropped whatever we were doing and started to work on COVID-19. And some of us started to model the COVID-19 using animal models, and others were trying to learn from the patients what's going on to the immune system in the COVID-19 disease. So one of the first things we had to do was this great disruption leading to construction, meaning new way of approaching science. And that had to do with from basic science in mice to human translational research. And there was a lot of learning that I personally had to do, as well as the rest of my lab, in terms of logistics, how we approach this problem experimentally, and also how we analyze human data, which is quite different from what we normally do in the animal experiments. And then the next sort of challenge or construction really had to do with how we approach science, from lab-centric to team-based science. And this was a dramatic shift in the way we were interacting with each other, not just sort of the Zoom versus in-person kind of meeting, but also from one lab to several labs around the world, and data sharing, which became a very important part of this science in the pandemic, particularly the use of preprint servers. And then personally, managing large groups of people all over the world, across the world, became a very important task for me with respect to transparency of communication, expectations that everyone has about each person's role, as well as balancing, research and family life. I have two daughters who had to do remote learning as well. So balancing all of that together at the same time, trying to balance a large number of groups became quite a learning experience. I did summarize some of these in a recent personal view in Neuron for anyone who's interested. Next slide, please. So the reason I said from bench to bedside to the world is because during this pandemic, we as scientists were also called to communicate science-based facts and scientific expertise to the world. And, I do communicate with multiple different platforms, including Twitter and more traditional media like the New York Times. We've also written some op-eds about certain misinformation that was circulating. This is just an example of vaccine hesitancy that was, quite strong in pregnancy. What would happen to pregnant women if they're vaccinated? There was a lot of confusion and fear among young women because of the exclusion of pregnant women from vaccine trials, combined with misinformation and disinformation. And what can we do to change this in the future? I think this is an important thing that we have to think about now. Next slide, please. The other thing that's related to this is, when is it appropriate to use scientific data to inform policy? This has come up over and over again, and we are facing this right now with respect to many issues related to, booster and vaccine-induced immunity versus prior infection, mix and match. There are so many questions that everyone has on their mind, which science, is rapidly being done, but it's just not catching up with the expectation of the people, as well as, when is it sufficient for the science to inform policy? And this is clear and consistent messaging is challenging, because the data are changing, the variants are changing. The same message we had for the non-Delta may not apply for Delta or the future variants. So this has been another big challenge in the community. Next, please. So all in all, I think we need to really start to think, seriously about science communication as scientists. Scientists are generally tend to shy away from engaging the public. Scientists should, I think, in my opinion, pay back to society through communicating clear and fact-based, communication about issues that come up, using our own expertise. And how might scientists engage its critics most effectively? This is a topic I think all of us grapple with. Next, please. So I want to end with this slide, just highlighting what Dr. Eric Lander already talked about, which is the pandemic has impacted certain member of the community much more disproportionately, such as women and underrepresented minorities. And it's already known that female scientists suffered larger decline in research time and output compared to the male peers, especially those who have small children. And also during the pandemic, women are posting fewer preprints and starting fewer research, and just sort of having to take a lot of responsibility at home as opposed to in the lab. Also in the media, male voices have been dominating scientific commentary on the pandemic in many countries. And so this also needs to be balanced, because scientists come in very different colors. And also, to restore damage done by the current pandemic, what do we do now to restore this damage that was disproportionately affecting women and underrepresented minorities? And we need for the future to design better and resilient support structures to prevent this from happening again, and start to think about the steps needed. So there's a really nice article in UNESCO about all these issues, but I just wanted to highlight these before I go to the next panelist. Thank you.
Great, thank you, Akiko. We will next hear from Dr. Saad Omer. Dr. Omer is the director of the Yale Institute for Global Health. Saad is a professor of medicine and epidemiology at Yale University, School of Medicine and Public Health. So Saad, the floor is yours.
Hi, could you project my slides? It's my pleasure to be here, and it's my pleasure to talk about consequentialist research in a fact-resistant pandemic. I'm a big fan of research that is non-consequentialist. We shouldn't ask questions too early about why someone is studying zebrafish biology, because if we don't ask the question of relevance too early, we get some of the most exciting things on the applied side, for example. But within the pandemic, there's a strong case of focusing on immediate consequentialist research where we say, what are the challenges and work backwards to finding the right disciplines and finding the right team. So I will share my experience, which is a small, tiny portion of what happened, but it's an illustrative example of how several groups came together and try to answer tough questions. And in my perspective, the ones that whose output I personally like took this approach that look at the question, work backwards to disciplines and teams, and then the output. Next, please. So there were three warnings at the outset. And I wrote this op-ed in the New York Times on January 23rd, 2020. And those of you who have written these op-eds know that you have very little control over the headline, but you can make suggestions, etc. The title was somewhat provocatively, and this was written when there was one confirmed case of COVID-19. It wasn't even called COVID-19 at that time in the US. So there was one confirmed case in the US. There was obviously news from China, etc. And the title was, Is America Ready for Another Outbreak? And the subheading was even more provocative, at least the first part. It said no, but there are clear steps the government needs to take. And the first warning, next, let the scientists lead. Not just because it's parochialism and I love and I like, hanging out with my peers and they should, be the philosopher kings of the world. The reason was that we knew, and that's the argument I put forward, that this pandemic, this new virus will change in unpredictable ways, or this outbreak at that time could evolve in unpredictable ways. So therefore, those who are closest to synthesizing and assimilating new evidence should be closer to decision-making. Next. The second warning was absolutely no false assurance. And it's now, I think, self-evident that doing so hasn't served us well. Next. The last thing was that there will be new sources of public and scientific misinformation. A third of my portfolio has been on vaccine acceptance and some of that work. The rest is more conventional clinical trials and epidemiology, and now increasingly in collaboration with basic scientists, et cetera, like Akiko actually, that we have worked on some of these questions. But the idea was that there will be preprints, I argued, were a force for good, but they can also be a force for a source of misinformation and sometimes disinformation. Unfortunately, all of these warnings turned out to be prescient. Next. So a few examples. One of our earlier studies, it came out in a National Academies journal, it turns out, a bit later, but our preprint was shared in May, June, I think, 2020, and where we looked at what is the impact of policy versus voluntary behavior when you implement sort of shelter-in-place orders. So I collaborated with economists in our School of Environment, so borrowed from that field, and we worked together to figure out, and what we found was it's actually both of these things matter. People start modifying their behavior voluntarily, and we used in this case a sample of cell phone data, and we figured out that the behavior would be modified even if you didn't put in shelter in place. So there would be, as a consequence, impact on the economy if you didn't have these quote unquote lockdown orders. But these orders actually have an impact on social distancing and time spent at home. So both the voluntary behavior and policy interventions are important. And we tried to quantify and went into some mechanisms for that. And you can read the full paper. Next. The other thing was, in as early as fall 2020, we were thinking with other groups that there is some pandemic fatigue setting in. And then we looked at national surveys, and we identified that we created a non-pharmaceutical intervention adherence index with colleagues and found that initially there was a lot of compliance in the US, but then it dropped. And there was some difference between regions, but then it leveled off. And so we started talking about the preemption of the impact of this pandemic fatigue as early as late 2020 and early 2021. Next. And then there was a signals. There were these early reports, and we knew from SARS-CoV-1 that you should be looking at feces, broadly, both for transmission, but there was this other blip of data that someone had identified viral RNA in feces. So look, I work in global health a lot, and there's always, the glass is never 90% empty, it's always 10% full. So the hope was, could we use this as an alternate mechanism to follow the outbreak and even predict the outbreak? So we worked with Jordan Peccia at the School of Engineering. He's an environmental engineer. And the idea was, could we identify this in sewage, but not also identify SARS-CoV-2 RNA in sewage as a way to monitor the outbreak, but also use it, apply epidemiological methods to see if it could warn us even by a few days of surges, etc. Next. And we did, next as well. So we did do that, both through epidemiological analysis and sort of data from the sewage. And this was done, this work started during the harshest lockdown, where students from various groups, including medical students, engineering students, went down manholes to collect specimens. And as a group, this was one of the earliest academic outputs on this topic, not just identifying the RNA, but also using it as an epidemiological tool. And it wasn't sort of one person's doing. It is, again, team science, starting with the problem, working backwards to the solution. Next. And then I was fortunate to be a part of the committee that the Academy is formed on coming up with an equitable allocation of COVID-19 vaccine, but also was fortunate to have a similar role as a member of the WHO COVID-19 vaccine working group. And we came up with the mortality first approach. One could argue that you could go in different directions, but I think because of the fact the second, third order of priority has been different, and now we are reaching in certain countries a level where we could attempt to interrupt transmission, the fact that the initial focus on mortality has held out. And here the reason why I brought up this slide is, look, a lot of comprehensive medicine, medical education programs and PhD programs have courses on ethics, behavior, etc. And those of you who are at earlier stages of your career, pay attention to them. They have good, solid information. It's often delivered by world experts. And those are the things that come in handy when you have to integrate this information, even at this level during a pandemic. Next. And then a lot of groups have been doing vaccine effectiveness studies. We did vaccine effectiveness studies, leverage, in this case, the VA database to look at vaccine effectiveness in high-risk population. But again, I don't think we have leveraged enough of our electronic systems to do those vaccine studies and ask nuanced questions. And we all admire the work, the fantastic work coming out of Israel. But the reason why they had been able to do this is their health system. Of course, it's a smaller country, but we have smaller parts of our large country. And I think we need to have these investments in data systems, and again, so that these questions can be answered quickly and efficiently. Next. And then the issue of vaccine acceptance. So we did this 12-country study with, again, an economist collaborator in this case, and we found that overall low and middle income countries, while there is heterogeneity and there needs to be work done on vaccine acceptance, the acceptance is higher, almost irrespective of the subgroup, in low and middle income countries of a COVID vaccine. And the reason it turns out it's important is now the talking point has been used as a red herring to not have vaccine equity, that these countries are not prepared to deploy vaccines. Frankly, we never had that discussion. We had data in May 2020, and other surveys were showing that there will be some softness of demand in certain sections of the US society, but we never had that discussion in the US that we should not have enough supply of vaccine because there is some work to be done on the demand side. Next. And now we are doing social media studies in collaboration in 5 countries with partners such as UNICEF, Facebook, and Public Goods Project, where we have already done in our initial stage 27 campaigns designed and launched with minimal investment compared to advertising budget Tens of millions of Facebook users have already been used, and we already have certain lessons from these randomized trials. So with each campaign, we run a randomized trial and learn from this. The next step will be actually measuring on-the-ground coverage. Next. And we have found that values-based messaging works, and local language content is more penetrable. But again, this insight on values-based messaging, and it's not just a warm and fuzzy word, there's a whole science behind it, and we use the moral foundations theory to come up with specific values-based messaging using social media's own insights. That has helped. Next. And lastly, in July 2020, a few of us got together. I partnered with colleagues in Stanford and University of Indiana who were law professors to come up with a framework based on some of the empirical data all of us had generated over the years, to come up with a framework of vaccine mandate that said that all of combining data, combining ethics, combining law, you should have 6 triggers before you implement a mandate. The pandemic should be inadequately contained. The vaccine should be ACIP recommended, not just FDA authorized. There should be adequate supply, transparent communications, infrastructure to deliver it to all sections of the populations, in inadequate voluntary response. And so that has been shared with policymakers, and some of it is intuitive on their part, but that kind of a framework has been found useful by at least a few people. So again, another example of partnering with starting with a question, working backwards to solutions in a pandemic. Next. And then we generated several products around vaccine misinformation management field guide with UNICEF, with First Draft and Public Goods Project. Those are partners there. And this has been translated in multiple languages, a vaccine messaging guide, and with WHO, an overall acceptance guide. And the reason I'm bringing it up is often there's a lot of recognition that we need to communicate effectively. But often we don't realize that there's a whole host of evidence behind it. And we owe it to the public that we apply the same level of rigor in vaccine communication science and public health communication science as we do in vaccine development science. Next. So here are a few examples of consequentialist science. Many other groups did it much better than our group. But the idea is, and the reason why I took this frame is because the national academies, and especially National Academy of Medicine, because of the fact that it broadly defines its discipline, its mandate, its intake of members is broad from various subdisciplines of medicines and adjacent disciplines, makes it very suitable for addressing a lot of these consequentialist challenges as they arise, and in between those challenges that are not just short-term emergencies, but long-term problems like global climate change and its impact on health. I'll pause here. Thank you.
Thank you, Saad. Next, we will hear from Dr. Matthew Wynia. He is a professor at the University of Colorado School of Medicine and Colorado School of Public Health, and is director of the Center for Bioethics and Humanities at the University of Colorado. And before I hand it over to Matt, I just want to just mention that if we have time, we will be happy to take some of the questions from the audience and offer up some answers. So you can leave questions, and I will be provided with them, and we'll see how much time we have for questions at the end. So great. So Matt, the floor is yours.
Thank you so much. It's a tremendous honor to be included in this discussion today. I was just inspired by Dr. Omer's list of tremendous research accomplishments over the last 18 months, and it actually a little bit both emphasizes and is a counterpoint to one of the main points I want to make today. I'm gonna just make 3 points. I'm going to point out, number one, we don't have the evidence we ought to have to make policy decisions in this pandemic, and that's because we don't have the infrastructure we need to be gathering evidence on a regular basis when there are disasters. And I'll give a little bit of data on that from a recent National Academies report that I was involved in. And then number two, I'm going to say there is an intractable ethical challenge in gathering good information, especially clinical information to guide clinical decision making, in the sense that individual doctors want to be able to move forward with the best evidence they've got, and yet we really need their engagement in order to collect better evidence to inform decisions so that we're sure that the things we're doing really are making a difference in a positive way. And that is fundamentally a complex adaptive challenge for which there is not a simple technical fix, but there are ways that we could do better, and they have to do with adaptive trial designs and things like that. And then the third point I'm going to make is in medical science, we've known about the hype cycle and the hype pipeline for a long time. They're very real. And what we're learning now is that they are also evolving, so they don't just involve professionals anymore. And there are significant consequences of that dynamic that I want to spend just a minute on. So let me go to the first slide and start with this point one, which is that we don't have the evidence we ought to have. This is from a study completed in 2020, so pre-pandemic, or almost entirely pre-pandemic. The study chair was Ned Kalange, and Autumn Downey and Lisa Brown did an amazing job on an enormous study lasting over 2 years, examining the evidence base for public health emergency preparedness and response, looking at all the research done in these domains over the last 20 years since 9/11. And I've circled the area here where I was most involved, which was looking at research on non-pharmaceutical interventions. So that's things like masking, distancing measures, quarantine, business closures, travel bans, and so on. And you'll note, number one, compared to some other areas of public health emergency preparedness and response, there's actually a fair number of research articles in this area advance just one to put the circle around non-pharmaceutical interventions. So that 10% represents about 125 studies, but only 10 of those studies were actually quantitative studies that were comparing two alternative interventions of the type that Saad just mentioned a moment ago, sort of RCT type research on pandemic response or on public health emergency response. So next slide. So the question here, this is the conclusion from our study, but the question to be raised here is, why is there so little evidence? And I'm not going to provide all the answers to that. We can talk about it in Q&A, but you all know there are many challenges to conducting rigorous research of the randomized controlled trial type during a pandemic. And I think the question we need to face today is, what is the infrastructure needed to ensure that every time there's a major disaster, we learn from it to improve our resiliency, our prevention strategies, our response strategies. We really don't have, in the way that we have an NIH to look at basic science around specific disease types, we don't have a piece of our national scientific that is really designed, purpose-built for disaster response studies. So next slide. Next point here is that there is a barrier to evidence collection that is an ethical dilemma, and I'm in bioethics, so I felt like I really had to hammer this home. If you can hit advance once more, I'll just put a quote up from this terrific article from the New York Times last summer. So next, please. There it is. I just thought this article, by the way, if you didn't get a chance to see it when it came out, is very well worth looking up, because it really describes stories from ICUs about people in this dilemma together. Desperate patients and their doctors who serve as their advocates really want access to potentially promising drugs as quickly as possible. They don't always feel like they can or should wait for definitive trials. Once they have a sense the benefits are likely to exceed the harms, they want to be able to move forward. And yet, without definitive trials, we'll never know if the interventions we're using are actually effective or possibly are harming people. And we've seen multiple examples of this during the pandemic. I'll mention a couple as we go here. Next slide. This is a great example of how we manage this problem very early on. It seemed like convalescent plasma made a lot of sense. The FDA gave it an emergency use authorization. And not only that, started advertising around the country saying, if you've had COVID and you've recovered, here's something you can do to feel like you are making a contribution to the COVID response. And I mentioned before, there are a number of things that drive us in the direction of trying things because they seem like they might be a good idea. Unfortunately, issuing an EUA and this level of sort of hype around convalescent plasma means it took a long time, and it took mostly trials from overseas. If you could advance once more here, and then advance once more. It took us too long, really, to find out that convalescent plasma doesn't really work. Notice the date on this paper. This paper didn't come out until a couple of weeks ago, and we've been using convalescent plasma for over a year. Next slide, my last point. There are multiple reasons, some of them are listed here, why scientists, their institutions, the news media tend to hype exciting new findings. And the traditional way of thinking about hype in science is to approach this as a matter essentially of professional self-regulation. And the public in this instance is seen as sort of the victims. They are at the receiving end of the hype pipeline. Go to the next slide. The challenge here is that social media is changing this equation. While interventions to prevent hype focused on reining in professionals are valuable, they're not going to work once the information has sort of escaped the scientific community and is out in the world and is the subject of hype by non-professional actors. Next, advance once more. So you know, and this is just one example, but political leaders, social media influencers are now an integral part of what we used to call the hype pipeline. Hydroxychloroquine is just one example. I'm sure you can think of others. Next slide. And in fact, this is my last slide, but it's just a brilliant quote, I think, from a group in Brazil, looking at how to address hype in this new environment where professional self-regulation will no longer be sufficient, because we have to learn how to defuse information, misinformation, hype, after it has been released into the world. And there are at least, I'm going to just give you two reasons for hope about this. There's a lot of reasons to be cynical, a lot of reasons to be a little down about the challenge of addressing misinformation once it has become widely disseminated. But I think there are two things to think about that give us hope. Number one, there are multiple studies, and Saad mentioned these as well, on rebutting and debunking misinformation. There was some early concern years ago that rebutting false beliefs can actually backfire and end up entrenching the mistaken belief. But more recent studies in social psychology find this backfire type effect is actually not that common. There are several studies have looked at backfire effects, specifically when looking at politically polarized issues, specifically even looking at people who self-identify as political conservatives and so on. And it turns out countering misinformation works. It doesn't work perfectly, but even when you're dealing with very polarized and very sort of difficult issues like environmental dangers of fracking or what causes pay gaps between men and women, real data can supplant misinformation. And there are a number of effective techniques, things like presenting facts in a causal, explanatory manner as a story, right? If someone has a story already, the way to change that is to replace it with a different story, showing how correct information can actually fill in gaps that the story contained because it was filled with false information. And last, the second reason for hope, you might worry that social media is billions of people, so there are billions of nodes of potential misinformation. There's a little truth to that, but it turns out network modeling shows there are social media focal points. So NPR reported last spring, for example, that there are really 12 people out there who put out most of the misinformation on vaccines. So these points need to be mapped and surveilled, and misinformation coming from these points can then be addressed more quickly and more effectively. So I'll end there and look forward to the conversation.
Great, thank you, Matt. Thanks so much. So our final speaker of the panel before our discussion will be Dr. Yvonne Maldonado. Bonnie is a professor and chief of the Division of Infectious Diseases, Department of Pediatrics at Stanford University School of Medicine. She is also the Senior Associate Dean for Faculty Development and Diversity at the Stanford School of Medicine. So Bonnie, the floor is yours.
Thank you so much. I am an infectious disease epidemiologist and a pediatric vaccinologist working primarily in the global health sector. So the work that I've done with COVID, I'm not going to talk about today, but certainly have been involved with clinical trials, epidemiologic studies, laboratory-based genomic analyses, et cetera, that have really served, I think, to help us disrupt and construct new models about how to affect and address new pandemics and the existing pandemic. However, one area that I think we really need to focus on, and sadly, I think we have not really done a great job of even disrupting yet, much less constructing and learning from, is what are social determinants. And we have a long history of trying to understand these social determinants, and nowhere has it been more starkly revealed how these social determinants have come to play in the health of our nation, in the health of our world, and how we have essentially ignored these areas, even with research policy frameworks. So clearly, more disruption and construction needs to take place. And I'm going to talk a little bit about that today, and hope that all of you can really take these back to your own areas of research and remember that these are critical. So if I can get the next slide, please. As we all know, since 1980, the Healthy People Initiative has set measurable objectives to improve the health and well-being of people nationwide. Healthy People 2020 first introduced social determinants of health. So it's only been a few years since we even saw these objectives since they started in 2010. And we do have Healthy People 2030, including social determinants of health. Now, these are also shared in general with the World Health Organization, recognizing that social conditions and environments are shaped by a wider set of forces, including economic and social policies. Healthy People 2030 is the 5th iteration of this initiative, but only the 2nd that includes SDOH. And these include objectives in 5 domains, as shown here: healthcare access and quality, neighborhood and built environment, social and community context, economic stability, education, access, and quality. So next slide, please. So why are these important? Well, we can see there are many papers in this area, but just 2 bar graphs here show you, or pie charts show you, that if you look across Europe, US and Canadian studies, and there are many others, as I mentioned, looking at social determinants of health as compared to medical or genetic determinants, they far outweigh the impact on not only disease, but wellness in all populations. So between 30 and 50% or more of our health, our longevity, all of the determinants that keep us healthy and well are not determined by our genetic code, but as they say, by our zip code. Next slide, please. Now, I like to look at the PAHO framework, although WHO also has a nice framework for addressing social determinants of health and equity. And the reason I really enjoy looking at this particular framework is that there is a greater emphasis on structural racism, colonialism, and the importance of relationships to land. There's also a greater emphasis on the environment and climate change, and a more explicit focus on human rights, inequities according to gender, ethnicity, sexual orientation, life stage, and disability. It also recognizes the interrelations between these and emphasis on leading dignified life as a desired outcome. Now, this conceptual framework is also helpful in another way, is that it really does look like it's an interplay. So you can enter this particular framework at any place and really take it all together, move from one framework to the other, taking a comprehensive approach to tackling these structural determinants of health and the inequities that we face not only in the US, but around the world. Next slide, please. So what do we have to guide our research in the US? Well, there are many frameworks. You saw the PAHO policy framework, but even within our own federal agency, we do have frameworks not only for healthy people, but from a research perspective, the NIMHD does have its own framework, as you can see here, looks at levels of influence, domains of influence, and health outcomes. And fortunately, we can see that these are areas that we can study specifically in either one box or another, or even multiple boxes, to look at influences of social determinants in a research-based manner. Now, unfortunately, this is only one institute, and the funding for these are quite difficult. I would just have to be honest. I personally had a U54 in this area from NIMHD, and we're currently working with RADXUP, that is Rapid Acceleration of Diagnostics for Underrepresented Populations. So we have received funding in these areas. But as you heard before, along with the science, these grants came through, about a year after we knew about the pandemic. So we clearly need better ways to address not only the basic research that's involved here, but how do we rapidly engage underrepresented populations, health equity issues, and get those going very early on when there is a crisis. Because with many of these populations that we're discussing, the underlying allostatic load, the underlying social determinants that lean in a negative sense towards poor health are already in existence and are ready to push these individuals and these populations over the ledge. So if I can have the next slide, please. So let's talk about the overarching issue. What is the overarching issue here around that big chasm? And again, remember, we're talking about today going from policy to equity. Here's the reason why we cannot do that. This is the house that racism built. Racism is viewed as a dynamic societal system shaped by that and reshapes other social institutions, such as the political, legal, and economic system. This is the bedrock on which our country was founded and many other societies as well. The pathways by which racism affect people are interrelated and mutually reinforcing, and importantly, implicit biases, which again, as a dean in this area, I deal with on a daily basis. And we continue to see that implicit bias can drive and lead to and reinforce these inequities in political, legal, and medical institutions. It is ingrained into our social fabric. Next slide, please. So what do we mean by social determinants of health? Now, I know that this is a very simplistic approach, but many people really still don't understand. What are we talking about? And what does this mean in an individual person's life or even in a community? Well, we're talking about things like poverty, frontline jobs, crowded living spaces, reliance on crowded public transportation, social food deserts or swamps, and inadequate insurance coverage. And all of us who saw patients, who did clinical trials, who did epidemiologic analyses, even those of us who worked in the laboratory, saw these individual factors and more play out in our populations at risk for COVID-19 specifically. And we know that these will continue to affect people, not just COVID-19 related, but any other aspect of their lives, because they are on the margin. And how are they on the margin? Let's look at the next slide. So if you look here, this is just a very small example of some of the areas that people looked at in this Kaiser Family Foundation survey: experiencing loss of employment income, difficulty paying usual household expenses, and food insufficiency in the household. This, to me, is the most heartbreaking one. As a pediatrician, watching children who don't have food on the table in a very vulnerable period of their lives. And you can see that it was quite extensive during COVID-19, even with all of the social safety nets. But those safety nets didn't reach all of our populations. So in black there, you see the populations in the racial and ethnic minority populations who really experience the highest risk for just these three factors. And we can imagine, I can go on and on about maltreatment of children, developmental disabilities and delays, obesity increases in populations at risk, et cetera. So this is quite a very small snapshot of what health inequities will do, not only for this COVID-19 pandemic, but for health overall. So next slide, please. So what can we do? Well, this is just one small area, but I'd like to point out the Social Vulnerability Index that was put together by the CDC many years ago to identify communities that need support before, during, and after public health emergencies. And this is a really simple tool, but it's actually a powerful one. It's an open database, and it's a measure of social determinants using census data and zip code. And you can rank each county and census tract on 15 social vulnerability factors, grouping them into socioeconomics, housing composition and disability, representation of racial and ethnic minority groups, and housing and transportation. And these data can be used for research purposes, they can be used for policy purposes, they can be used for direct public health interventions. Next slide, please. And how does this play out for COVID? This is a striking example of how easily this can be mapped out. So here on the left, you see that social vulnerability index that I just mentioned. And you can see that overall, when you scale high levels of social vulnerability to low levels, with the darker blue being higher levels of inequity and lighter being lower levels of inequity or no inequity, and you overlay that map from last year's COVID-19 hotspots or case counts per 100,000, and they are almost a perfect match. So you can see how social vulnerabilities really drove this pandemic, especially early on. And not only that, I can't go through it now, but if you take this down to a more granular level, you can see by pulling out those counties there on the right, you can find out whether rural counties or urban counties were more involved, whether household density was an issue. And you can do this not only overall in this big map, but you can do it by census tract and you can do it by county. And individual public health officials, researchers, et cetera, can go in and tease out individual factors by region and really try to make a difference. So if we really are serious about making a difference and not just publishing papers and talking about white papers, how to get social determinants on on people's radar, we need to actually get into the weeds, pound the pavement. I'm a CDC trained epidemiologist, and our symbol is the shoe with a hole worn through it, because we pound the pavement. We go out there, you find the people who are at risk, and you do something about it. And I think this is where bridging that chasm between policy and equity really lives. And I'd like to stop there and thank you for your attention.
Thank you so much, Bonnie. That gives us a lot to think about. So one of the things that kind of came back to my mind as I was hearing each of you speak was that some of the key problems that you were pointing out with what has happened during the pandemic, in a sense, they're problems that are far from new. And I'm thinking of myself as a journalist. I and my colleagues, we have written in the past about, the problems of structural racism. We have written about the challenges that women in science face. The hype cycle is not new. I remember blogging about it years ago. Even the understanding that miscommunication could lead to bad outcomes in terms of health. I mean, we've been dealing with that, even just with vaccines for years. So it feels, I get the impression from the presentations that in some ways on the cusp of the pandemic in January 2020, we already knew what a lot of the problems were, and then they happened. So I'm kind of wondering maybe if each of you might want to reflect on I mean, if maybe I'm wrong, but if you agree with that, like, what was the disconnect? If we understood, for example, that trials are often poorly set up to really come up with good outcomes, so that we end up with a situation like convalescent plasma, where it takes months to figure out, well, maybe this isn't all that we had hoped for. If we knew about these problems and had these tools in place at the beginning of the pandemic, why did they continue to be such a problem during the pandemic?
So let me go ahead and give a start. I mentioned I trained at CDC. We've known for decades, that public health is seriously underfunded in this country, and I don't think it's appreciated well. It's very hard to prove a negative. So we know that if you avoid disease, it's very hard to show that there's actually a success there. But there's actually also some reason for hope, because if you look overall at our public health structures in the last century, I think we've done an amazing job. We just need to keep moving forward. I think we've been sitting on our laurels for too long. And at the global health level, if you look at the Millennium Development Goals through the next stage, the Sustainable Development Goals, we did as a world, there was tremendous progress. So when people understand, if there's a call to action, if you really put emphasis in these areas, you can really make a difference. Now, obviously, we lost a lot of ground over the pandemic globally, but not as bad as we thought we had. And I think unfortunately, we live in a crisis mode. Many of us do. I think the world lives in, let's solve the next big problem. I teach a class on epidemiology of infectious diseases, and we always say that the media attention to a disease is inversely proportional to the incidence of the disease. So let's take advantage of this moment in history to really start that process and not forget why we did it, and make sure that we build these teams, these collaborative teams, not only among researchers, not only among public policy makers, but our communities of color, our communities around the world, our lower and middle income colleagues, and make sure we build all of those connections and have actionable items that we can really move towards.
Thanks, Bonnie.
So I'd be happy to go next.
Sure, great, Saad.
Yeah, so I think I really agree with Bonnie, and I think these are really good. It's a good diagnosis, and I'm not going to repeat that. And I think all of these causes, quote unquote, loosely using the word. I know there are people who work on, who may be listening, who actually work on causal inference, but so hence the caveat. And so I think these are important. But I would go a little bit deeper, if I may. I think proximal causes are important and useful and need addressing. But at this pandemic, it wasn't a failure of science, fortunately or unfortunately. We knew how rapid tests were done. We knew PCR was invented way before. We knew how cohort studies are done. We knew how randomized controlled trials and pragmatic trials were done. Ivermectin is old, and its limitations could be recognized earlier. We knew there's a whole body of research on vaccine acceptance and public health messaging, etc. All of that is there. I think if we had a failure, and this is not a partisan statement, and I'll qualify that, why I'm saying it's not a partisan statement, it was a failure of governance. It was a failure of governance to let it slide that public health preparedness funds were cut and were not reinstated, and public health departments were starved of resources. It's a failure of governance spanning multiple administrations that looked at public health as a sideshow and looked at, got enamored a little bit too much by technological solutions rather than leveraging technology for a consequentialist purpose. Coming back to what I said earlier, it's a failure of governance that treats global vaccine equity as an afterthought. It is in our self-interest, not just because history will judge us poorly if we have another big surge like India during the winter months in Nigeria or Kenya or any other large country or a small country. As it is, mortality is high enough in many parts of the world, justifying immediate action on global vaccine equity. But it is also in our self-interest to ensure that we minimize opportunities for the virus to mutate. So all of this stuff, it's not just in recent past. It's not a failure of science. It's a failure of governance. And it's not a failure of governance in a partisan sense. It's a failure of governance that we as a society as a whole need to pay attention to, not a specific administration. Obviously, there's accountability in democratic societies for individual administrations, but that's not what I'm focusing on.
Great, thanks. Akiko or Matt, I don't know if you had anything you wanted to add.
I'll build on what Saad just said. I agree this was a failure of governance, and the strategies of governance are amenable to scientific examination and study. As you know, because you've done some of these kinds of studies where you approach problems in a couple different ways and see which one works better. And we have opportunities for this every time there is a disaster, every time there's a drug shortage, every time, right, there is a resource shortage of any kind. We have an opportunity to learn more about how to effectively allocate scarce resources. And we've largely failed to do that. So I think it is a failure of governance, and I'd love to see research on these governance issues. And I'd love to see a home for that research. I think there will be funding for it now because we're coming out of a pandemic. That funding will eventually dry up because we've seen this cycle before. When there's a major national disaster of some type, we get an infusion of funds, and then 8 or 10 years later, it's gone. And if we are wise about this, I think there is infrastructure that can be built with those funds. There are structures that can be established that might allow for ongoing research and learning over time beyond this, what will inevitably be a wave of funds to prepare. But what's going to prevent us, after the 2009 H1N1 pandemic, which fizzled in terms of how many people it killed, but it was still a major event, and it depleted our national stockpile of N95 respirators, which were then not replenished. What's going to prevent us from having to learn those lessons again and again, right? And that's where I feel like having some infrastructure in place that will synthesize lessons learned and make sure that we are, as we do with kidney disease, as we do with heart disease, as we do with cancers, we need to build the evidence base for public health emergency preparedness and response. And that requires a comprehensive strategy and core infrastructure suit to purpose.
Yeah,
Thank
I
you.
just want to so thank you, Saad, for saying it's not a failure of science. In fact, there's a lot of drugs and treatments that were examined in the preclinical studies around the globe, including my own laboratories, that have prevented sort of some of these other drugs from going forward that may not have had any impact or even harmful impact. So there's this sort of unseen science that was done to prevent some of the non-promising candidates from going forward. And I think that's sort of underappreciated, that a lot of us sort of chipped in and did this research during the pandemic, which is never comes to surface.
So we just have a few minutes left. Maybe just we could round things out. We, instead of looking at the deep problems that were sort of highlighted in the pandemic, I'm just curious, like if any of you, if there's anything in particular, a lesson that's new and surprising to you over the course of the pandemic, something that kind of popped out, like you thought, wow, I hadn't thought about these kinds of challenges before in this particular way, or here is a totally new tool that I want to use going forward. And what would be one of those surprising new lessons that you really hope that your colleagues in future generations don't forget, so that you really hope will be, it can be a big thing or a little thing, but just maybe one thing that, if you could put it in a time capsule for future generations, people would remember it from this experience we've had. We can go in the same order. How about you, Bonnie?
Yeah, I would say, frankly, again, unfortunately, I wasn't surprised by this pandemic. Obviously we didn't know it was coming, but we knew something was going to happen. We worked with other pandemics in the past in this country and other countries. But what I think was really startling was the power of the collective. That's what really was amazing to me. given the fact that we were relatively isolated from one another in physical terms, virtually the collective really pulled together to highlight specific issues for good and for better or worse. So for example, we had the Misinformation Collective, but we also had the Youth Collective. We had people who were really highlighting social issues, highlighting the societal structures, the gender-based issues that came up that we had really thought about, but I think really hadn't pulled together. And I think that power was vibrant, it was palpable, and I do think that's something we can tap into. One of my colleagues, and I won't say who she is, but she might remember, years ago, we were talking about a vaccine that worked really well in the developed world, but not well in the developing world. And she was asked if she was a glass half empty or full person. And she said, I don't look at it that way. I just look at how big the glass is. And I think that's what Saad alluded to earlier. And I think that's a great way to look at it. With this collective approach, it doesn't matter what increment we make. Any incremental change is going to make a difference. And that's where, but again, we have to be careful because that collective can work for good or for, I wouldn't say evil, but just for at cross purposes for the good.
Great. Saad, quickly, like your favorite lesson that you wanted to hold on to?
Well, I will say that I will borrow from an international affairs scholar, Tom Nichols. His hypothesis, I think he has a book coming out saying that that the U.S. is an unserious nation in terms of. I think it's unfair to just single out the U.S. The global society is increasingly unserious, and the reason I'm saying that is that we have an increasing proclivity towards fluff, towards talking points, towards varnishing uncomfortable truths, towards what is the output for the next grants and the preliminary data for the next R01, rather than looking at the big picture, looking at what is, and this is, I'm drawing implicit lessons from the great recessions of 2008, 2009, where it was the earning reports, not the long-term health of companies. Similarly, I think we are going in that direction, both as a society, as science as well. So I think we have to get serious because the big climate change, big challenge in health that is coming, it is already at our doorsteps, is the planetary health impact of global climate change. All of these things like inequity, gender imbalance, our inability to operationalize science, and all of that is going to be pretty substantially of a pretty substantial magnitude and more sustained in that, for planetary health, etc. So as a summary, I'm not saying that we need to stop cracking dad jokes, as my students know that I have an unhealthy taste for corny jokes in my class. I'm saying that we should, as a society, get serious about looking at real solutions, not looking at short-term press releases, and making sure that the science is up to the challenge that is in front of us, which is planetary health.
Great, thanks, Matt.
Yeah, once again, I think I'll build on what Saad has just said. I think there is a sense in which we tend to varnish the truth and the difficulties of some of the situations we face. And in particular, I think the pandemic has really raised to the surface, among many other things, the explicit tension that sometimes exists between efficient use of limited resources and equitable use of limited resources. And that tension between efficiency and equity is an intractable problem. It will never be solved perfectly. But what the pandemic has done is really forced the issue. And I think insofar as we had tried in the last 40 years to subvert that issue and say, no, we can have it all. We can have high efficiency and we can achieve equity. I think that the pandemic has shown us that that may not be true, that in order to achieve equity, we are going to have to pay something. And the question is being raised, what are we willing to pay to ensure a more equitable future?
Great. Thank you. Akiko?
Yeah, so I resonate with what Bonnie said about the different collectives. I think there's a really nice parallel in science that what I've learned and what others have learned is the sort of the power of scientific collective and team-based science. And this is something that I not only will put in a capsule, but will carry through, I think, in the rest of my career to do this team-based science. And there's a fundamental problem in the way in which scientists are evaluated by authorships. And this was also, highlighted by Dr. Eklander's talk. But we need a circular authorship. We need to kind of have everyone in the team be sort of valued at the same time with the same emphasis. And that's not happening in science. And often it's the first and the last authors that are emphasized. But if we really want to value team science, the way in which we evaluate science and scientists also have to change. So that's something that perhaps a capsule would help in the future.
Great. Okay. All going in the time capsule. Thank you so much. And thanks to the Academy for inviting me to moderate this fascinating panel. And I hope the audience has learned as much as I have. So thanks to everyone.
Thank you.
Well, I want to thank panel one. That was absolutely stunning and great moderation and great comments. Please join me in thanking this fabulous panel.